So this will be the first podcast in our series on human genetics, and I'd like to introduce our course with a clinical case. So we have a 25-year-old woman. She's pregnant for the first time and presents at 17 weeks for a routine anatomical ultrasound. Her pregnancy is uncomplicated. She had a previous dating ultrasound at 6 weeks that was normal, but the present findings show short fetal long bones that appear to have multiple fractures. The fetus appears to have a contracted chest circumference, and there's absent or irregular bone mineralization. And these findings are actually consistent with Osteogenesis imperfecta type 2, which is an absolutely lethal condition. So the question is, what do you do? How do you counsel this patient? Some background information on OI. This is an inherited disorder of connective tissue. It's sometimes called brittle bone syndrome. It's usually inherited in an autosomal dominant manner. 85 to 90% of the cases are autosomal dominant, where there are mutations in the collagen genes. Perhaps 10 to 15% of the cases are autosomal recessive conditions, and here there are mutations in collagen-associated genes. And if it's an autosomal recessive condition, you need to have 2 copies of the genes for the disease to be manifest. Now, if someone has the autosomal recessive form of OI, 100% of the offspring have to be carriers. And I'll ask you to think about that for a while. That'll become clear as we go through the genetics course. Now, most cases of OI are due to mutations. Type 1 collagen mutations can be in the collagen 1A1 gene, which is located on chromosome 17 on the Q arm, or the so-called long arm. There may also be mutations in the collagen 1A2 gene, which is located in the long arm of chromosome 7. Mutations in other genes are also possible. Osteogenesis imperfecta type 2 is the most severe form of the disease. It is lethal. It turns out that there are 8 known types of osteogenesis imperfecta. OI type 2 generally involves mutations in the collagen 1A1 gene, and babies that are born with this disease will die very early in life, usually from respiratory issues. And as in our case here, the disease can be provisionally diagnosed in utero with ultrasound, and the spontaneous mutation rate for OI type 2 is approximately 1 in 50,000. So back to this case, what do you do? The patient was counseled that the recurrence risk for this disease was very low, and of course baby would have been born and would have shortly died. There's no family history of OI. The woman is in a monogamous relationship with her husband, and it's not a consanguineous relationship. The following year, the patient is pregnant again, and she delivered a normal boy at 39 weeks. The next year, the patient is pregnant for a third time, and she has a normal ultrasound at 7 weeks, but an anatomical ultrasound at 17 weeks revealed identical findings to the first pregnancy. So the couple elected to undergo an amniocentesis to obtain materials for genetic testing, and then they elected to terminate the pregnancy. Genetic analysis revealed mutations in the collagen 1A1 gene, which is consistent with osteogenesis imperfecta type 2. So what happened? Did this woman hit the lottery a second time? Because the odds were 1 in 50,000 of a spontaneous mutation for OI. A fourth pregnancy was uncomplicated, and the lady delivered a healthy boy at 39 weeks. So how in the world do we explain these findings? Well, they can be explained by something called germline mosaicism, and this most likely occurred in the father. And here is a pedigree of an individual. This individual male is normal. His somatic tissues are normal, but a significant percentage of this person's sperm, it turns out about 12%, contain a mutation in the collagen 1A1 gene. Now, This man is not the husband of our patient, and you can see that in this case, this man fathered children by two different women, and both of them had osteogenesis imperfecta type 2. Here is a pedigree from our family. This individual is probably a germline mosaic for Osteogenesis imperfecta. That's what the cross in the symbol means. And you can see that in this case, the first pregnancy is lost. Obviously, the baby died. Normal baby boy. This was the elected abortion, where the fetus again had OI type 2. And then the fourth pregnancy, a normal baby boy. Both of these parents are phenotypically normal. This child and this child are healthy, normal boys. You might want to think, would you expect these boys to father normal children when the time comes? That's an interesting question to think about. This couple chose not to be tested themselves, and after the fourth pregnancy, the husband underwent a vasectomy. This is actually a real case from our Department of Obstetrics and Gynecology. So, as an introduction now to the genetics course, if you think about how genetics has been changing over time, I'd like to play for you a little bit of a report from National Public Radio to just set the stage.
Deciphering genetic codes has become quick enough and cheap enough to leave the laboratory and enter the consumer market. People curious what their genome says about their health can buy a genetic reading, and the price is getting cheaper. In the first part of our series, the $1,000 genome, NPR's Rob Stein reports on how this became possible.
Ever since Watson and Crick cracked the genetic code, scientists have been fascinated by what they could learn from reading our genes.
For the young scientists of the future, there are many exciting questions ahead.
Here's how a TV special captured that fascination in 1960.
Can we learn how to read the codes in DNA?
If scientists could read the secrets in DNA, they knew they'd solve all kinds of mysteries. How do mistakes in our genes make us sick? What about our DNA makes us different from one another? But the power of DNA has also long raised lots of fears.
In the not-too-distant future,
In 1997, those fears were dramatized in the sci-fi film Gattaca.
a minute drop of blood determines where you can work, who you should marry, what you're capable of achieving.
That was science fiction, but just 3 years later, President Bill Clinton walked to a podium in the East Room of the White House.
Good morning.
He announced this once futuristic dream of reading someone's entire genetic code, their genome, had become a reality.
We are here to celebrate the completion of the first survey of the entire human genome.
So that's just a brief teaser. The link here actually shows the link to the trailer for the movie Gattaca, and actually on YouTube you can watch the whole movie if you're so inclined. So clearly we live in the post-human genome world where we've sequenced the human genome, and the results with respect to the future of medicine are going to dramatically change. Genomic testing for disease likelihood, treatment, and management is becoming almost commonplace now in medicine. For example, genome sequencing and genomic testing is very important in cancer diagnosis. You might think of, say, breast cancer, and you think of that as the same disease, but in reality it isn't true. Genes that will drive one woman's breast cancer might be different than genes that would drive another woman's breast cancer. So being able to test for these is becoming critically important, not only in cancer, but even in diseases like celiac disease. I'm not going to go over this here, but we know that variants of, for example, the HLA genes can place individuals at different risks for celiac disease. This is all where genetics is going. And it's even interesting, only a couple of years ago, there was a case before the United States Supreme Court that had to do with whether companies could patent human genes. And it turns out that the court ruled 9-0 that you cannot patent human genes. As we go through our human genetics course, we hope to provide you with basic concepts of genetics for application in the context of understanding congenital and acquired diseases. We hope to provide you with concepts so that you can begin to think about underlying genetic components to disease and to begin to think about how genetics is transforming treatment and patient care. And our course is going to build on things you've already studied in anatomy and embryology and in biochemistry and molecular biology and certainly in cell biology and histology and physiology. Course objectives: when you complete this course, you should be able to describe gene structure and discuss the organization of the human genome. You should be able to describe basic principles of cytogenetics, recognize chromosomal abnormalities and relate these abnormalities to human health. You should be able to summarize and, we hope where appropriate, identify classical patterns of Mendelian inheritance. You should be able to calculate and or predict patterns of inheritance through pedigree analysis. You should be able to diagnose genetic disorders if we give you enough information. We hope you can describe and, where appropriate, identify consequences of mutation and genetic variation on health and disease in human populations, and you should be able to discuss the impact of genetic screening and counseling as related to diagnosis and management of disease. Now, in any genetics course, you should find and use a good textbook, and one textbook that we particularly like is Medical Genetics by Jorday. There should be a 5th edition that should be due in the fall of 2015. There are also a variety of useful websites that you might look at when you are studying genetics. One of them is the online Mendelian Inheritance in Man site. Another one is the Multiple Congenital Anomaly Mental Retardation Syndromes from the U.S. National Library of Medicine. Also, a very useful one is Gene Reviews, and another one you might look at is the Genetics Home Reference. These are all very useful websites. YouTube can be a very good source to give you insight into how patients might present with different genetic syndromes. You can get a sense of how they behave, you can get a sense of what the anomaly might look like, and even how patients will interact with their families.